السلام عليكم.
وعليكم السلام ورحمة الله.
طيب إن شاء الله today we have three lectures. The first one will be presented by Dr. Abdulillah Al-Qahtani, short-term mechanical support. Then the second lecture will be by Dr. Abdullah Shihri, the long-term mechanical support. And the third one will be the momentum third trial, the journal club, with Dr. Muslim Al-Musawi. Our guest is the consultant, Dr. Haytham Al-Zahrani from King Abdullah Medical City from Mecca. Inshallah, we wish that it will be a valuable and interactive presentation. Abdulillah, you can start.
Thank you.
Assalamu alaikum.
Assalamu alaikum, everyone. Can you hear me?
I can hear you. Assalamu alaikum. هيثم الزهراني.
بسم الله الرحمن الرحيم. حياك الله يا دكتور.
سامعيني كويس؟ الو؟
ايوه تفضل.
Yes دكتور. We are hearing you. Yes.
طيب تمام. I was just testing the connection. Excellent.
Are you seeing my screen now?
I cannot see anything at the moment.
One second. اي خلاص فتحت. بس الكاميرا مفتوحة الحين. طيب سويت شير، صورت لك والله العظيم. شوف سويت شير على الحمراء. طيب
السلام عليكم يا حسن.
عليكم السلام.
كان ستارت ذا سكند ليكتشر اذا عبد الله بياخذ وقت. يا حسن وزينب،
لا حياة لمن تنادي.
لقد اسمعت لو ناديت حيا. انا دق عليه الحين. السلام عليكم. سلايد واضح؟
وعليكم السلام. هذه اوكي، هذه اللونج تيرم ميكانيكال.
انا كلمت عبد الاله، قال لي عبد الاله طالب ياخذ وقت. عبد الاله
جميل جدا.
بسم الله الرحمن الرحيم. Today I will talk about long-term mechanical circulatory support. I am Abdullah Mohammed Al-Akrami من سعود الباطين كارديك سنتر دمام. In United States, heart failure remains a leading cause of death in over 250,000 annually mortality, and more than 5 million Americans are living with heart failure. The cost of medical care for the heart failure is high and exceeds 30 billion every year. Heart transplant is still the ultimate therapy for advanced heart failure, but it is limited with the shortage of donors. Mechanical circulatory support with ventricular assist device is becoming more and more as it is safe and effective treatment strategy for patients with end-stage heart failure that is refractory to medical therapy. The first clinical application of an LFAD was performed by Dr. Debeki in 1963. He used the device as a temporizing measure in patients with cardiogenic shock after AFR. The pump functioned good, but the patient died with pulmonary complication 4 days after its implantation. And here in the picture, on August 8, 1966, Dr. Debeki implanted an LFAD in a 37-year-old woman with severe heart failure who could not be weaned from bypass after aortic valve replacement. The pump was taking the blood from the left atrium to the right axillary artery. After 10 days, the heart recovered and they electively removed the pump. She later returned to the work and resumed normal activity and survived for 6 years with good cardiac function before she died in a motor accident. And this was the first successful LFAD. This is Dr. Denton Coley and this picture from National Museum of American History in Texas for the first total artificial heart implanted in the human body. It was implanted by Dr. Coley on April 1969 in Houston. The recipient lived for about 3 days with artificial heart until human heart was available for transplant. Indication for long-term mechanical circulatory support generally follow the same indication of heart transplant. The concept of long-term mechanical circulatory support developed concomitantly with the field of heart transplant, as ventricular assist device were originally started as a temporary bridge to transplant. And it was an effective strategy to rescue patients with advanced heart failure till they can get a new heart. Or it can be used as an alternative to heart transplant, which is known as destination therapy, and in some patients as bridge to decision in case of temporary contraindication. Today, as the number of patients who are supported by FADs continue to increase, those indicated as destination therapy constitute about 50% of the patient, whereas bridge to transplant constitute about 26%. For the remaining 24%, the other indication include bridge to decision, which suggests the possibility of transplant evaluation after FADS implantation, and bridge to recovery, which offer temporary mechanical circulatory support for the duration of acute insult.
That's a good point, Abdullah. Can I stop you there, please? Oh, you're going to talk about these things in detail. That's good. Okay, go ahead. Go ahead.
The shortage of donor heart around the world has led to a steady rise in number of candidates requiring bridge to transplant with LFAD support. Bridge to transplant nowadays is the most common strategy for mechanical circulatory support. About 65 of these patients are designated as transplant candidates, but around 20% only are officially listed for a transplant at the time of device implantation. The 2010 report from this International Society for Heart and Lung Transplant documented growth in bridge to transplant population from 13.4 the period 1992 to 2000 to 20% for the period 2002 to 2006, and approximately 85% of mechanical circulatory support involves isolated LFAT use, whereas the remaining 15% of cases may involve BiFAD support in the form of BiFAD or even total artificial heart. Bridge to recovery, which offer temporary mechanical circulatory support for the duration of acute insult. In a selected group of patients, an improvement in ventricular function may allow for device weaning and sometimes deactivation. In a recent publication in Journal of American College of Cardiology demonstrated that among 80 patients with both ischemic and non-ischemic cardiomyopathy, implantation of continuous flow LFAD resulted in 50% increase in ejection fraction in 1/3 of the patient after 6 months, and 50% reduction in LV in systolic and in diastolic volume, and reduction in LV mass 1 month after implantation. About destination therapy, utilization of fat as destination therapy means durable, lifelong alternative to transplant for patients with end-stage heart failure who are not eligible for transplant to prolong or improve the quality of their life. The designation of destination therapy originates from rematch trial, in which transplant ineligible patients supported by mechanical circulatory support had better outcome than patients supported by medical therapy only. In 141 centers in the United States, the percentage of LFAD implanted as destination therapy has tripled over the last decade, from 14.7 in 2006 to about 46 in 2014. And in a recent report from Journal of Heart and Lung Transplantation from 2014, it's reported a 1-year survival rate greater than 80% and 2-year survival greater than 70% in over 10,000 patients in Intermax database who receive continuous flow LFATs. And it's mentioned in the American Heart Association Heart Failure Guidelines 2022, destination therapy mechanical circulatory support provide considerable survival advantage in addition to improvement in functional status and health-related quality of life.
That's a good point. Can I stop you here for 1 second? Just wanna. The rematch trial was, as you said, was a game changer, and this was in 2014. And the device at that time was a very primitive device. It was the Heartmate 1 or the Heartmate XV. It was not a continuous flow LVAD, it was a pulsatile LVAD. Okay, and despite all the shortcomings of that device, it showed a significant survival benefit in patients with advanced heart failure over medical therapy. So as the technology progressed over the years, the survival now is much better with LVAD therapy. With modern 3rd generation LVADs now, the number needed to treat, do you know this statistical concept? NNT, number needed to treat patients to save 1 life of heart failure is 1.7. You need to implant 1.7 LVADs to save 1 death, which is a very low number. Yes, 1 life. The number needed to treat with the CRT device to save 1 death is, I think, is more than 10. So the effectiveness of LVADs in preventing death in advanced heart failure is more than 10 times the effectiveness of a CRT device. So this tells you the magnitude of the benefits that patients with advanced heart failure receive when they get an LVAD therapy. Okay, you can continue.
The growth and development of mechanical circulatory support has spurred several initiatives, including the creation of ISHLT, International Society of Heart and Lung Transplant, or in 1999, and later the Intermax in 2006, which are global registries intention to evaluate outcome among adults receiving mechanical circulatory support. As the FAD implantation remains a highly invasive intervention, patient selection requires a careful multidisciplinary evaluation of patient before implantation. It is very important for outcome after LFAD implantation and is performed by a specialized team in LFAD implanting center to take the indication and contraindication into consideration. Committee usually include at least one cardiologist, one cardiac surgeon, FAD coordinator, social worker, and palliative care specialist. One we can note point has been shown to contribute to patient outcome is center experience. In a novel study done on 2017, it realized that low center volume, that's been average LFAD less than 10 per year, was associated with 8% lower survival at 1 year compared to high volume center that do more than 50 implants per year. And the hazard for other study, the hazard for 90-day mortality was significantly increased among patients implanted at low volume center. There are several definitions for classification of heart failure and advanced heart failure. The European Society of Cardiology update its definition and of advanced heart failure, which now include 4 distinct criteria focused on refractory symptom rather than cardiac function, including those with isolated RV dysfunction or uncorrectable valvular or congenital heart disease, and in patients with reserve and mildly reduced ejection fraction. Other definition is Intermax score. It is one of the various attempts to stratify risk prior to implantation of mechanical circulatory support, which divide advanced heart failure into 7 different risk levels. Intermax plus 1, also called the crush and burn status, comprising approximately 15% of all implantation, signifies highest degree of acuity and critical cardiogenic shock, whereas a score 7 is hemodynamically stable heart failure with minimal symptom. Majority of patients receiving FAD are Intermax 2 and 3, with the percentage of 36.4 and almost 30%. And as per evidence by Intermax class 1 patient having reduced survival at 1 year compared with class 2 and 3, 74% versus 82. At the other end of the spectrum, growing evidence suggests that implanting FADs in ambulatory heart failure patients, that's mean class 4 to 7, which comprise about 20%, have excellent outcome, approaching 80 to 95 survival at 1 year.
Can you go back to the Intermax score, please, Abdullah? Can you hear me?
Yes.
Very good. So, in intervening in patients with heart failure, there is a window of opportunity where they can benefit. Once they get to Intermax 1 and 2, as you said, their outcome is not as good. And let's say if you have a crash and burn situation, Intermax 1 patient, you don't put a durable long-term LVAD in those patients, because those patients are usually very sick with multi-organ failure. They're coagulopathic, they're acidotic. So you put them on a short-term device, either an Ecmo or a Centrifugal. You correct their hemometabolic dysfunction, you restore their organ perfusion. Then, as a second step, you put in the LVAD. So really, your window of opportunity is intermax 3 and 4, 3, 4, 5. Okay, so you catch patients in this. You try to actually to get them in this window of opportunity before they deteriorate. So if you get intermax 1 and 2, it's actually not advised or not good clinically to put them on a long-term LVAD. Number one, as we said, because they're hemometabolic derangement, acidosis, coagulopathy, and you're not sure they're going to survive the event because they're really sick. And it's a very expensive therapy to implant in a patient whom you're not sure how they're going to do. So basically, you rescue them with a short-term device, and then once they improve, you put in the long-term device.
That means this group you will stabilize first with short-term.
Yes.
Then you can decide later.
Exactly. So some residents get confused. Intermax 1, they have bad outcome. Intermax 1 don't get a long-term LVAD, period. When you get them at Intermax 1, you put a short-term device. You put an Ecmo with a vent, or you put in a temporary LVAD like a Centrifugal, or in pediatrics you put in Berlin Heart, or an Impella, percutaneous LVAD, but you don't implant a durable long-term LVAD in Intermax 1 patients. Okay.
This is American Heart Association Heart Failure Guidelines 2022. Class 1 indication to use mechanical circulatory support in selected patients with advanced heart failure with reduced ejection fraction, with class 4 symptom, who are deemed to be dependent on continuous IV inotropes or temporary mechanical circulatory support. Durable LVAD implantation is effective to improve functional status and quality of life and survival. Pre-op assessment, right heart failure is the leader complication of left ventricular assist device placement, and is associated with higher incidence of early morbidity and mortality. And beside intermax classification, or the evaluation of right ventricular function is very important, as there are no reliable option for long-term right ventricular support, and it is thought to occur in 20 to 30% of patients, especially early post-op after LVAD implantation, and is the primary cause of death in about 10%. Early right heart failure happened during first month post-implantation and has been defined as short or long-term right side circulatory support, continuous inotropic support for more than 2 weeks, or the use of nitric oxide for more than 2 days after LVAD implantation. And the incidence of right heart failure is about 20 to 30%, and many criteria are formulated to try to predict pre-op right heart failure after LVAD implantation, and recently a risk score based on Euromax data was developed, in which phasic pressure measurement, echocardiogram, and clinical parameters were combined. And based on this score, reasonable prediction of early post-op RV failure can be made. One study identified laboratory marker including AST level more than 80, a total serum bilirubin level more than 2, and serum creatinine more than 2.3 as independent predictor of post-implantation RV failure. Other study described preoperative circulatory support, female gender, and non-ischemic heart failure etiology as the risk factor for right heart failure. About valvular heart disease, the utility of concomitant cardiac and valvular procedure is poorly understood and remains controversial. whereas some studies have suggested that concurrent procedures are associated with diminished overall survival. Consensus opinion does support intervention in a specific situation. Aortic regurg or aortic insufficiency creates a circulatory loop in which blood pumped into aorta regurgitate back into LV, and this leads to forcibly elevated estimation of LFAD flow with associated systemic blood perfusion. Closure of aortic valve result in commissural fusion of the valve leaflet, which may end up with aortic insufficiency or stenosis, or progression of pre-existing aortic insufficiency. Fortunately, increased mortality has not been observed in LFAD patients who develop moderate or severe aortic insufficiency. Correction of aortic valve pathology at the time of LFAD implantation remains controversial.
Can I stop you here, please, Abdullah? Aortic insufficiency, you said correction of aortic insufficiency is controversial at the time of LVAD?
Yes.
I disagree with this. It's an absolute must to correct anything more than mild aortic insufficiency. Mild, you leave it, but anything more than mild, moderate, or severe has to be corrected. And you mentioned the reason. It creates a circulatory loop. Okay, and it defies the purpose of an LVAD. The purpose of the LVAD is to unload the left ventricle and push the blood systemically. If you have an insufficient aortic valve, all the blood pumped by the VAD will go back into the left ventricle. Not all of it, most of it. And basically, this circulatory loop, number one, will make heart failure much worse. It will not treat the heart failure of the patient. They will still have high LVEDP, high filling pressures. They will still complain of heart failure symptoms. They will not have good systemic perfusion if you leave them with aortic insufficiency. Absolutely has to be corrected. Anything more than mild aortic insufficiency, either with an aortic valve replacement or with a Park stitch, something called a Park stitch.
Yeah, I would talk about Park stitches.
Exactly. So it's not controversial. Correction of aortic valve insufficiency is indicated at the time of LVAD.
Which kind of valve you prefer, mechanical or tissue valve?
Counterintuitively, because we think that these patients are anticoagulated, it's better to put a mechanical. The answer is no. It's better to put a tissue valve because of the high risk of thrombosis with a mechanical valve. If you put in a mechanical valve, the valve will be in a closed position most of the time because the patient mostly will not be ejecting blood through the valve. The valve will be in a closed position, and this will form thrombus on the valve. So, tissue valve. You put in a tissue valve in these patients at the time of surgery if the valve is not repairable. So, tissue valve, despite the fact that they will be on anticoagulation long term. And the reason is with mechanical valves, there is a high risk of valve thrombosis. Okay?
Right heart failure was observed more frequently in patients undergoing concomitant valve procedure, and this was directly related to the severity of tricuspid regurg. In several single institution studies, concurrent tricuspid valve procedure in addition to LFAD placement have been associated with decreased rate of right heart failure and shorter duration of hospitalization. And however, these studies have not demonstrated a mortality benefit associated with concomitant tricuspid valve intervention. And in one Society of Thoracic Surgeon database analysis, concomitant tricuspid valve surgery was associated with increased rate of renal failure, increased time on the ventilator, longer ICU length of stay, and greater transfusion requirements.
So should we repair tricuspid valve or no, Abdullah?
Yes.
We should? What does everybody else think? Any other thoughts from the audience?
Giving this statement, we should consider not to touch or add the concomitant surgery to it.
Okay, so exactly. So this is a controversial topic. addressing tricuspid regurgitation at the time of LVAD. There are two schools of thoughts in this. Some surgeons always fix the tricuspid valve, some surgeons leave it alone. Okay, and there is growing evidence that if you actually correct tricuspid regurgitation, there is an increased risk of RV failure post-op. And there is, as you mentioned here in one of the STS database analysis, increased risk of renal failure, ventilator time. That's correct. That has been observed more recently. And the reason is the tricuspid valve is actually acts as a top-off valve, is a vent basically for the high pulmonary pressures. Okay, so once tricuspid regurgitation in those patients is basically a survival mechanism. They survive. The RV survives in those patients because the RV can vent. There is tricuspid regurgitation. Once you close this venting mechanism, you basically restrict that RV completely, and the RV fails. A lot of the time you get away with tricuspid valve ring, but it's actually been associated with adverse outcomes, according to my recent knowledge of the literature. So it's still a controversial topic, but I wouldn't do it. I would not address tricuspid regurgitation at the time of LVAD surgery.
Even if it is severe, Doctor?
Even if it's severe, yes. Even if it's severe. Because it's functional TR. We're talking about functional TR. Functional TR is basically from high PA pressures. PA pressures should drop when you put in an LVAD. Once you unload the left side, the PA pressures should improve. And this is a point we will talk about in the bridge to candidacy. Some patients have very high PA pressures that preclude them from being transplant candidates. And in those patients, you put in an LVAD, their PA pressures drop, and they can become transplant candidates again. So addressing tricuspid regurgitation, functional tricuspid regurgitation at the time of surgery is a controversial area, but I would not address it. I would leave it alone for medical therapy, for diuretics, things like that. Okay.
Psychosocial evaluation, one of the important components of LVAD patient selection is psychosocial evaluation. Current guidelines for LVAD patient selection include screening for psychiatric disorder, history of drug abuse, and other psychosocial issues that may affect the ability to comply with LVAD care. Multiple studies have investigated the utility of psychosocial screening among prospective heart transplant candidates. Limited data exists to describe psychosocial factors associated with LVAD outcome. About frailty, it is a state of vulnerability to adverse outcome, and it has been associated with increased morbidity and mortality among patients with cardiovascular disease. And understanding and quantifying pre-LVAD frailty is yet another integral component of patient selection process. Signs of frailty include unintentional weight loss, poor grip strength, slow gait speed, and low physical activity. While cardiac tachypsia and exercise intolerance stemming from advanced heart failure are traditionally associated with poor outcome, LVAD implantation offers the possibility of reversing or at least improving this pathologic process. There is a frailty score used to qualify frailty based on individual health impairment called deficit index. Depending on this score, there is one study from Mayo Clinic. On average, patient had deficit in about 29% of the area assessed. An increased 1 year mortality was observed with increased deficit index, and after stratifying LVAD recipient into frail, intermediate frail, and not frail cohort based on deficit index, The hazard ratio for 1 year mortality was 3-fold greater for frail patient and 1.7 times greater in intermediate frail patient within this population. Patients considering for long-term mechanical circulatory support frequently present with a variety of comorbidities, include obesity, diabetes, and renal insufficiency. While no individual comorbidity is regarded as absolute contraindication to LFAT placement, each presents a unique challenge in the care plan and should be considered in the patient selection process. Regarding the obesity, multiple retrospective studies suggest that obese patients do not suffer significantly worse survival at 1 year. However, it can increase the rate of device or drive line infection and rehospitalization in extremely obese patients.
This is a good point, Abdullah. Obese patients, we know that morbid obesity is a contraindication to transplant. Why? Do we know why? Morbid obesity is a contraindication to transplant?
It's high risk of infection and mobilization, difficult mobilization.
No, it's hemodynamic actually. It's a hemodynamic contraindication. Basically, you will struggle to find a matching donor. Okay. These patients will end up on the waiting list because you have to match the donor size, body size, BSA, with the BSA of the recipient. So morbidly obese patients usually last on the wait. They die on the waiting list. Okay, so we don't list them. Morbidly obese patients are not listed, and they always have a degree of obstructive sleep apnea, pulmonary hypertension. Okay, so their pulmonary hypertension also is not completely cardiac, has a obstructive sleep apnea component to it, and they're not listable patients. So their only avenue for advanced heart failure therapy is LVADs, and they actually do well. We have a very obese patient locally here who received Heartmate 2 a few years ago. He's still alive with the device, doing very well. And I'm sure in other centers you encounter those patients. And in my training, I encountered a lot of obese patients. They do well on the LVADs, and a lot of them they lose weight and they can become transplant candidates. So obesity is not a contraindication to LVAD. In fact, they benefit from it. It's a contraindication to transplant. Okay.
Regarding diabetes mellitus, although it is independent mortality risk factor in heart failure patients, but in patients with LFAT, diabetes was not associated with stroke, pump thrombosis, device-related infection, or all cause of mortality. And it can be successfully managed with LFAT with similar mortality compared to non-diabetic patients. Chronic kidney disease, it is estimated that approximately 2/3 of patients living with heart failure suffer from some degree of chronic kidney disease. Renal dysfunction is strongly associated with poor outcome after device implantation. In fact, previous literature has demonstrated that every 1 ml per minute reduction in creatinine clearance is associated with 1% increase in mortality among patients with heart failure. Other study compared peri-LFAT creatinine clearance to level at 2 weeks post implantation, and at least one study has found the 2 weeks post implant creatinine clearance to be more predictive marker for survival than baseline GFR. The previous pulsatile pump technology was dominated the clinical application of device in the 1990s and early 2000s. The most important conceptual basis of pulsatile pump was based on 2 general important concepts. First, delivery of pulsatile fluid that mimic the native circulation. Second, delivery of adequate stroke volume, which was in the range of 50 to 70 ml per pump per systole. As a result of these two concepts, the design limitation of this device mandate that the pump to be large enough to accommodate the required stroke volume. This limitation plus concern related to long-term durability is the primary reason why newer pumps are all based on rotary devices that generate continuous flow of blood throughout the cardiac cycle. These devices have quickly become the standard of care for patients suffering from end-stage heart failure. The small size of this pump has proven to be a major advantage, allowing their use in patient population with a small body, including women and children.
Sorry, Abdullah. Just one comment. Yes. So yes, exactly. The first device that was designed, everybody thought that the pulsatile technology that mimics the physiology of a normal human is best for the patients. And everybody turned out to be wrong, because a device that moves all the time with each pulse has moving parts, and the more it moves, the more damage happens to the moving parts, and the durability of the device is not good. So this is what happened with the Heartmate XVE. So many explants for pump failure and pump thrombosis. Moving parts are not good because they actually fail, because they move all the time. Then it changed to continuous flow with the Heartmate 2, axial flow pump, and the Heartmate 3 and the hardware were centrifugal flow. And as the technology progressed, all these complications got less in terms of device failure, thrombosis, and so on and so forth. Okay, continue.
I will talk here about the most three common devices, which are Heartmate 2 hardware and Heartmate 3. The Heartmate 2 is an LVAD started in early 1990s. The device weighs 290 grams. The rotor is the only moving part, which provides superior device durability. In vitro, the Heartmate 2 is capable of producing flow rate greater than 10 liters per minute, as resolution ranging from 8,000 to 15,000 RPM. However, as in other continuous flow pump, there is a risk of pump generating negative intraventricular pressure, causing the ventricle to collapse, leading to arrhythmia, thrombus formation, or interventricular septal shift that may precipitate profound RP failure. As a result, clinically pump speed are set in the range of 8,600 to 9,600 RPM, generating estimated flow of 4 to 6 liters per minute, depending on RP function and pulmonary ventricular resistance. The Heartmate 2 received FDA approval as bridge to transplant device in April 2008, and in January 2010 approval as destination therapy. More than 20,000 implants of Heartmate 2 have been performed worldwide. The first United States multi-center randomized trial conducted at 38 centers for destination therapy indication compared patients receiving Heartmate 2 with 133 patients to pulsatile Heartmate XVE with 59 patient device in 2-to-1 randomization protocol. The Heartmate XVE was the only pump approved as destination therapy by FDA. The median duration support was 1.7 years for Heartmate 2 and 0.6 years for XVE. All patients were followed up for at least 2 years or until death, transplant, or device explant. The primary endpoint was a composite survival at 2 years, free of disabling stroke or pre-operation to replace the device. The primary endpoint was achieved in 46 patients in Heartmate 2 compared to only 11 patients with XVE patients. Survival at 2 years was 58 for Heartmate 2 versus 24 for XVE device. Both groups had significant improvement in functional capacity and quality of life, and device replacement was less frequent in Heartmate 2. Regarding hardware from Medtronic. It weighs about 160 gram. Received approval.
So you know that this device is off the market now.
Yes, it's pulled from the market.
Completely removed. So we can skip it just for the sake of time. So this device, yeah, exactly. For the sake of time, I think, yeah, Heartmate 3, go.
The last mechanical circulatory support is the Heartmate 3, which is the newest type of valve that FDA has approved. Received FDA approval as a bridge to transplant device in 2017 and FDA approval as destination therapy in 2018. Momentum trial. Next lecture will be, we'll discuss momentum trial if you want to skip that slide. Or I can talk briefly about momentum trial.
Talk briefly and then.
Right. The momentum trial was the first major randomized United States trial to comparing patients who received the Heartmate 3 device to those receiving Heartmate 2. The trial was first study that moved away from terminology, bridge to transplant and destination therapy, and instead enrolled patients with the intention to evaluate them at 2 endpoints, 6 months as short-term growth and 24 months as long-term growth, regardless of overall attention for device therapy. In Heartmate 3 group, 86.2 patients reached the endpoint compared to 76 of the patients on Heartmate 2. The absolute difference of 9.4 was statistically significant with p-value less than 0.001. This primary endpoint was driven primarily by higher incidence of pump thrombosis in Heartmate 2 patients, about 10%, compared to none in Heartmate 3 patients. The other adverse event related to stroke, bleeding, sepsis, right line infection, right heart failure was similar in both groups, and the trial resulted in Heartmate 3 being approved by FDA as short-term device in 2017. Now we'll talk about implant technique and.
So can you go back to the Heartmate 3 slide, please? I don't know how much time do we have. Wait, why is the Heartmate? Why does the Heartmate 3 perform better than the Heartmate 2 clinic? What's different about the Heartmate 3?
It depends on the rotary pump.
Okay, can you explain? Or can anybody explain in the audience? Do we know the difference between Heartmate 2 and 3? Okay, so basically the Heartmate 2 is an axial flow pump. Okay, from the inflow to the outflow, the blood flows in one axis. Okay, it's a rotary pump that uses the Archimedes screw principle. The Heartmate 3 basically is a fully magnetically levitated device. Full magnetic levitation is a technology, magnetic levitation. There is a magnetic field that's generated inside the device, and the rotor of the device basically becomes exposed to this magnetic field, and it rotates. Okay, there is basically no moving parts at all in this device, in the Heartmate 3. No moving parts at all, and the pump housing is large. This has virtually eliminated all pump thrombosis events. There is no such thing as pump thrombosis with the Heartmate 3 anymore. So there is lower stroke rate. There is lower pump thrombosis rate. There is lower pump failure rate. You can still get stroke with Heartmate 3. The stroke rate between Heartmate 2 and 3 is similar. You can still get strokes with Heartmate 3 because you can still form clots inside the pump, but the pump will not be dysfunctional because of that clot. The clot will be sent away and cause a stroke. But the main difference is actually the technology is centrifugal pump, full magnetic levitation, and that one is an axial flow pump. And also the pump housing is large. And basically, which virtually eliminated all pump thrombosis events with the Heartmate 3. And that's why the Heartmate 3 performs much better clinically than the Heartmate. Okay, continue.
Implant technique, although it can be done minimally invasive, but the vast majority of clinical experience with device implantation has been sternotomy approach on pump. Although some have advocated for off-pump placement of device, the vast majority of surgeons perform on-pump device placement. Arterial cannulation is usually done via aortic arch cannula to have enough length of ascending aorta for outflow graft anastomosis and for later aortic anastomosis during heart transplant. During isolated LFAD implantation, venous cannulation can be done via insertion of dual-stage cannula. Separate inferior and superior vena cava should be performed if there is any additional ASD or BFO or reconstruction of tricuspid valve. There is indication to repair the tricuspid valve, or if the right ventricular function is severely impaired and RFAD implantation is potentially necessary, or if mitral valve reconstruction is necessary. Elevation of left ventricular apex is facilitated by inserting surgical gauze into the precardial cavity until the apex is nicely elevated. Using correct location for sewing ring is very important to ensure an unobstructed blood flow into the inflow cannula and the pump. The inflow cannula should point in the direction of mitral valve and should avoid directing the tip of inflow cannula toward the septum. We can assess radial position by either pressing the index finger of surgeon at the LP apex during TEE, or inserting long needle through middle of the sewing ring and controlling the direction of the needle by TEE. Once the correct position has been found, you have to mark the center of the sewing ring as well as the outer border. The sewing ring is secured using either 1 centimeter continuous felt strip and with a total 10 to 12 U stitch, 3 O Prolene, or like an here in the picture, we can use running stitch. The knot of U stitch can be placed within the securing ring, but then the end of the knot have to be cut short, so do not interfere with placement of pump in the sewing ring. The myocardium inside sewing ring is removed using a coring device. Obstructing muscle is resected to achieve free flow into the inflow cannula and check for potential thrombotic material between the trabecular muscle. And then tunneling the derived line and to facilitate the pull-through of derived line, we first insert thoracic or chest tube in the derived line tunnel. The derived line itself is placed within a few centimeters of the thoracic. Before the inflow cannula is placed in the sewing ring, the outflow graft has to be connected to Heartmate 3, and care must be taken not to twist the outflow graft while it is screwed clockwise to Heartmate 3. We will hear a click while screwing. This is normal. Screw with your hand and do not use any instrument. The firm screwing for solid connection is very important to avoid any further movement of the outflow graft, which rarely might occur up to 2 years later. And the inflow cannula can be now placed within the sewing ring. After the device has been implanted, adjust the orientation of the pump. The optimal path of outflow graft is directed toward the ascending aorta, having the correct length in mind. Measurement of the length of the outflow graft is very important to avoid cannula that is too short or too long. Anyway, the dacron has the tendency to stretch after certain time. The aortic anastomosis is performed with the partial aortic cross clamp using grunning for O stitch, proline, or for small felt strip. This anastomosis should be as long as possible to avoid any resistance to flow in the outflow graft. After the Heartmate 3 has been implanted and de-aired, then the flow of Heartmate 3 is started slowly with 1 to 2 liters to avoid any overflow of the right ventricle by LVAD. During this phase, inotropes are routinely given. The function of the right ventricle and the positioning of intraventricular septum are monitored by Ecmo and by hemodynamic parameter like CPB, pulmonary artery pressure, and cardiac output. And gradually increase LVAD flow, and full flow can be achieved slowly over half an hour to prevent RP failure. Nitric oxide is used very operatively as well as prostaglandin. About the outcome, the performance and publication of rematch trial was first evidence of survival advantage for LVAD technology over optimal medical therapy. Despite this gain, potential complication limit the widespread of mechanical support, and ongoing effort remains focused to maximizing survival advantage and minimizing the potential complication of these devices. With the publication of rematch trial came the first evidence of decreased mortality in patients with end-stage heart disease supported with mechanical circulatory support. There was 48% improvement in survival at 1 year. The 1 year survival for the device group was 52 compared to 25 in the medical therapy group. At 2 years, survival was 23% for the device group and 8% only for the medical therapy group. Quality of life has been an important component.
The data you presented were very old from the rematch trial. As we said, this is the first generation pumps. Survival 24% at 2 years is still considered poor, but much better than medical therapy. With modern LVAD, Heartmate 3, a lot of centers are presenting their data now, and it's actually the survival is equal to the survival of transplant recipients. Exactly. Okay.
Quality of life has been an important component of every FAD trial since rematch. The Heartmate 2 digital transplant trial done on 133 center. Functional and quality of life assessment at baseline, 1 month, 3 months, and 6 months after implant. Quality of life was assessed with this score and questionnaire. Functional status was assessed by NIHA class and result of 6-minute walk test. Measure of quality of life significantly improved after device implantation. Most patients had improvement in at least 2 NIHA class and improvement in 6-minute walk test by distance of more than 200 meters. The follow-up of the study data 281 patients assessed quality of life and functional status at 6 months. 83% of patients were NIHA class 1 or 2, and 89 versus 13% period were able to complete a 6-minute walk test. There were significant improvement in mean value of on this 2 questionnaire. About the adverse event, post LVAD implantation, and despite marked improvement in device design and clinical management, complications still occur frequently at all time points. According to 8th annual Intermax report, 60% of patients are re-hospitalized at least once by 6 months post-implantation. At 1 year, rate of re-hospitalization has been estimated to be as high as 65 to 80%. Intermax one at time of implantation has been correlated with higher risk of complication as would be expected. However, even among healthier patients who are not dependent on inotropic support, we mean intermax 4 to 7, is still high. The roadmap trial demonstrates high morbidity at 1 year follow-up with 80% readmission rate. Right heart failure after LFAD implantation outcome are heavily dependent on preservation of adequate RV function. And the right heart failure is defined by intermax as increased CPB more than 15 with echocardiographic and clinical sign of venous condition like right heart dysfunction, dilation, or significant tricuspid regurgitation. Right heart failure can occur in early post-op phase, but may also develop later in the course of the disease. It is the exact mechanism is unclear. It is believed to be driven by sudden increase in LV unloading and RV preload, which distort RV geometry and unmask underlying dysfunction. In addition, the septal leaflet of the tricuspid valve may shift and worsen the tricuspid leakage. Regarding bump thrombosis, is a multifactorial phenomenon which can result in rapid clinical deterioration and even may require emergent pump exchange, and it is negatively affecting the survival. Diagnosis relies on abnormal pump parameters such as power spikes, elevated hemolytic marker, and reduced ventricular unloading. Recent clinical trial data suggests that 10%, 10.7 to 12.2 of Heartmate 2 patients and 4.2 to 6.4 of hardware patients develop pump thrombosis and requiring device exchange in 2 years. Technical improvement led to almost elimination of pump thrombosis in Heartmate 3 as shown in Momentum 3 trial. Bleeding, major bleeding is defined as suspected internal or external bleeding resulting in death, resternotomy, hospitalization, or transfusion of red blood cells, either more than 4 units in first week or any transfusion after 1 week. Bleeding is most common complication and can cause readmission after FAD implantation. GI bleeding is most common, occurring 15 to 30% of patients across all device types, especially among older patients with previous history. And although bleeding most commonly occurring in the first 3 months of device implantation, it can happen at any time afterward. Different mechanism, but it's usually related to the use of anticoagulation and antiplatelet therapy in combination with acquired von Willebrand syndrome after LFAD implantation as a result of decreased pulsatility. Stroke, incidence of stroke, about 13 to 30% of FAD patients, and it's more in female patients. Stroke is not only an important cause of morbidity, but also a predictor of mortality. Mechanism behind ischemic stroke is believed to include embolic sources such as thrombus from the pump, aortic valve, inflow or outflow graft. Hemorrhagic stroke is believed to occur secondary to hypertension, endocarditis, and hemorrhagic conversion of ischemic function. The Endurance 2 trial demonstrate equivalent stroke rate between the centrifugal hardware and axial Heartmate 2 as long as hypertension is well controlled. The Momentum trial demonstrates lower incidence of stroke with Heartmate 3 device compared with the Heartmate 2, 10% versus 19.2% at 2 years. One of the complications after LFAD is aortic insufficiency. Mild to moderate aortic insufficiency has been reported to evolve in up to 25% of patients at 1 year of support. Progressive aortic regurg post-FAD implantation is significant barrier to long-term support. Mild to moderate aortic insufficiency reported to evolve in up to 25% patients at 1 year support, with more than 30% of patients reaching moderate or worse aortic insufficiency after 2 years. It's believed to be caused by device-generated pressure gradient across the aortic valve, leading to aortic valve closure and eventual commissural fusion, result in blood volume recirculation, increased pump work, and exacerbate heart failure symptoms. Surgical option for aortic insufficiency, such as aortic valve closure using part stitch, or they call it central portation closure, or replacement, or even with TAVI. All are available choice, but appear to increase risk of mortality whether it is performed concomitant at the time of valve implantation or later. Regarding arrhythmia, post LVAD implantation, ventricular arrhythmia are highly prevalent during mechanical circulatory support, about 30%, both in early post-op and later in the course of the disease. Ventricular arrhythmia might be tolerated relatively well. That means no loss of consciousness because output is preserved by LVAD. However, clinically patients may present with right heart failure. And most often, the underlying cardiomyopathy leads to ventricular arrhythmia, especially in those patients who old age had ventricular arrhythmia prior to LVAD implantation. The role of CRT after LVAD placement is not clear, and there is no agreement about ICD therapy in mechanical circulatory support patient, where a shock in unconscious patient is unfortunate, while on the other hand, ventricular arrhythmia are detected early to prevent right heart failure and hypoperfusion. Derived line infection, it is a common valve-related complication and is independent predictor of mortality. It might be limited to the exit site of the derived line, but may also extend to other parts of the system. Derived line infection in the soft tissue surrounding the outlet is most common, occurring in 15 to 23% in recent cohort study, and its rate are highest in first 3 months post-op. Although gram-negative roots such as Pseudomonas and Klebsiella, fungus, and Mycobacterium can cause infection, but gram-positive cocci, particularly Staph epidermis and Staph aureus, are most commonly identified pathogens. Patients often require long-standing antibiotic or surgical treatment, and in a recent study identified that the risk of LVAD-associated infection is increased in Heartmate 2 when compared with the hardware and in patients who need post-LVAD ICD implantation. In Momentum 3 trial, comparing outcome in Heartmate 3 versus Heartmate 2, device-related infection occurred equally in both groups. This is summary of most LVAD implantation complication with the diagnosis and treatment for your reference. Thank you.
Thank you, Abdullah. Excellent presentation. Any questions?
Thank you so much, Dr. Abdullah, and thank you for Dr. Haytham for his valuable input. If you have any comment or any question to Dr. Abdullah, you are most welcome.
Assalamu alaikum. First of all, thank you, Abdullah, for your presentation. Could you please just summarize the important differences between Heartmate 2 and 3? سامعني؟
ايوه الفرق بين Heartmate 2 and 3.
Yes, could you just summarize the important differences between Heartmate 2 and 3? I get your point that 2 is most common and 3 is emerging to be slightly, controversial, but seems to be a little bit better. But could you please just summarize the differences?
Dr. Haytham can correct me, but I think the Heartmate 2 is the most common worldwide operation, that more than 2,000, 20,000 worldwide. But the Heartmate 3 now is a newer device, And I'm not sure if there is anybody still implant Heartmate 2. And about the mechanism of action, as Dr. Haytham said, Heartmate 2 depend on axial flow, and Heartmate 3 on this rotary pump only. That means decrease of thrombosis, and there is no contact of or less contact of blood with the device.
So the flow configuration,
excellent.
what you're saying, is the reason why there is more thrombosis with Heartmate 2. Is that correct?
So basically, there are differences in the design. Number one, there are differences in the clinical performance. The differences in the design between the Heartmate 2 and the Heartmate 3. The number one difference is the direction of the flow, axial flow versus centrifugal flow. Axial flow is where the direction from the inflow to the rotor to the outflow is in the same angle, axial flow. There is something called the Archimedes screw, basically, where a helical screw is used to shift fluid from one compartment to another. And that is the principle of axial flow in the Heartmate 2. It is the same principle of flow in the Impella device, which some of you may be familiar with. So this is number one difference in the design. The Heartmate 2 is an axial flow pump that uses a moving part. The Heartmate 3 is a centrifugal pump that uses full magnetic levitation technology. And as we said, full magnetic levitation is a technology that uses a magnetic field where the rotor of the pump does not come in contact with the pump housing. It's fully magnetically levitated. Magnetic levitation is the same technology that is used in the trains in Japan. High-speed trains that go 400 and 500 kilometers per hour. The tires and the rail of the train do not come in contact with each other. The train is fully magnetically levitated from the rails. This results in high speed, train speed, and low friction, or almost no friction. The same technology is applied in Heartmate 3. There is no friction. There is no contact. There are no moving parts. Okay? No contact between the rotor and the pump housing, and no moving parts. No contact between the rotor and the pump housing means there is basically no pump failure, or very low risk of pump failure, and no moving parts also. And the gap between the pump housing and the rotor eliminates pump thrombosis. So this is the main difference. Why Heartmate 3 performed clinically much better than the Heartmate 2 was the low risk of pump failure and the low risk of pump thrombosis and pump exchange. And that's why Heartmate 3 performs better than the Heartmate 2. Is this clear?
Yes, very clear. Thank you.
You're welcome.
Thank you, Dr. Haytham. Thank you, Dr. Abdullah. So we'll have 10-minute break, then we'll join for the second presentation by Dr. Abdullah.
I have a question, if I can ask, please.
Go ahead, please.
Yes, please. Thank you for your time and great explanation that we got. I want to ask, what is your take of LVAD bridge to recovery? Because I have seen some cases been done here in Saudi Arabia, and it was intended to be for recovery, not for destination or for transplantation.
Bridge to recovery is actually not common to see. And if you see a lot of bridge to recovery in one center, it means that most likely that patients did not need the LVAD in the first place. And honestly speaking, but it happens, and pathologies that are more amenable to recovery includes things like acute myocarditis, viral myocarditis. Patients with acute myocarditis actually do recover. Giant cell myocarditis is steroid responsive. And some of those patients actually do recover their LV function. Steroid-induced cardiomyopathy in bodybuilders, I have seen that recover. So when you see LV recovery, you no longer need the LVAD. And there are two ways to deal with this. Either pump explant or pump decommission. Pump explant is where you completely remove the whole pump. Pump decommission is basically when you remove the drive line and remove the power source and you leave the pump inside the patient. It happens. It's probably, I heard it happens a lot in some centers. In my own experience in training, I have only seen it once or twice. Some experts say that if you expect that this pathology is reversible and this patient needs a long-term LVAD, it's probably better to use a Heartmate 2 than a Heartmate 3. Heartmate 2 is extrapericardial. It's easier to explant than a Heartmate 3, although it's bigger. But it's extrapericardial. It sits in the peritoneum, as you know. So if you think that this patient has a high likelihood of recovery, you should probably consider Heartmate 2. In my own experience, if I think this patient has a high probability of recovery, then put in a temporary LVAD, such as a Centrimag or an Impella. And let's say, yes, you have giant cell myocarditis, a patient with cardiogenic shock. Giant cell myocarditis is steroid responsive. You put in an LVAD, you put in an Impella or a Centrimag, you start them on steroids, they recover, you explant the device. It's much cheaper than implanting a Heartmate 3.
I see.
Okay?
Okay, very clear. Thank you, doctor, again.
You're welcome.
See you on 2:40, inshallah.
Thank you.
عبد الإله.
ايوه
You can start عبد الإله.
ان شاء الله باذن الله.
تفضل دكتور.
Okay, this is a short-term mechanical. Assalamu alaikum warahmatullahi wabarakatuh. Sorry for misconvenience that happened earlier. This is Abdul Al-Gahtani, cardiac surgery resident R5 from King Fahad Cardiac Center, King Khalid University Hospital. Today I'm going to present short-term mechanical circulatory support in cardiac surgery. Okay, let's start with introduction. So short-term mechanical circulatory support are designed to be used for a wide range of conditions, ranging from a prophylactic to management of cardiogenic shock, acute decompensated heart failure, or arrest. Patients in the shock require early aggressive therapy to restore a normal cardiac output and maintain end-organ perfusion. So cardiogenic shock in 2 to 12% of patients after acute MI, post-cardiotomy period in the range of 0.2 to 0.6%. Acute decompensated heart failure in chronic heart failure patients, severe cases of myocarditis, and postpartum cardiomyopathy. Each device improves the following parameters of circulatory function with some variations: end-organ perfusion, reduction in intracardiac filling pressures, reduction in left ventricular volumes, wall stress and myocardial oxygen consumption, and augmentation of coronary perfusion. So we have 4 major categories of circulatory assist devices. We are going through them one by one, inshallah. Intra-aortic balloon pump, the non-balloon percutaneous mechanical circulatory assist devices, Ecmo, extracorporeal membrane oxygenator pump, and non-percutaneous centrifugal pump, which are used for cardiopulmonary bypass. So we'll start with the intra-aortic balloon pump. Guidelines on ST elevation MI made the following recommendations for the use of the balloon in the following settings. Cardiogenic shock, this is not quickly, which is not quickly reversed with pharmacological therapy. Routine use of the balloon in cardiogenic shock is a class 3, is not recommended. In 2016, European Society of Cardiology guidelines for the treatment of acute and chronic heart failure. Acute MR, particularly due to papillary muscle ruptures or ventricular septal rupture. European Society of Cardiology guidelines for ST elevation MI suggests the balloon can be used for stabilization of patients with these conditions. So this is the device with the balloon, which is mechanism of action with inflation during the diastole and deflation during systole. Concepts, we have systolic unloading and diastolic augmentation. So in this diagram, you can see the major physiological effect of the balloon pump is a reduction of LV afterload, a reduction in LV systolic wall tension and oxygen consumption, increase in coronary perfusion pressure by 87%. Factors that affecting diastolic augmentation. Patient's factor, the heart rate, the mean pressure, stroke volume, systolic vascular resistance, the balloon itself factors, the intra-aortic balloon in sheath, not unfolded, position, the lab catheter, the balloon catheter leak or helium concentration, the intra-aortic balloon pump itself, the timing and position of the augmentation control. We are going to talk about these factors and errors in one by one, inshallah. So how to check waveform is acceptable or not. So first, change the augmentation from 1 to 1 to 1 to 2. Check the dichrotic notch, see if the augmentation starts. And at that point, this should produce a sharp V wave at inflation, as you see in the diagram. So check if diastolic augmented wave is more than systolic one in the red star. So this is mean it is acceptable waveform. Confirm if in diastolic wave following the augmented wave is less than the non-augmented wave. As you see here in the yellow star. So we are going to the timing errors. We have 4 errors. We start with the early inflation. Inflation of the balloon pump prior to aortic closure. So it's prior to the aortic notch, the diastolic augmentation onto systole infusion. So we may be unable to distinguish between these 2 waves. So physiological effects ends by potential premature closure of the aortic valve, potential increase in LV parameters, left ventricular end diastolic volume, pressure, and wedge pressure. Increase the wall stress or afterload of the LV, aortic regurgitation, and increase the myocardial oxygen demand. The second one is the rate inflation of the balloon markedly after closure of the aortic valve. Waveform characteristics after the aortic notch inflation, absence of sharp V wave, suboptimal diastolic augmentation that ends by suboptimal coronary artery perfusion. And early deflation, as you see here, it's a premature deflation of the balloon during the diastolic phase. Suboptimal diastolic augmentation, assisted aortic end diastolic pressure may be equal or less than unassisted aortic end diastolic pressure. So physiological effects, suboptimal coronary perfusion, retrograde coronary and carotid blood flow, angina may occur because of result of retrograde coronary blood flow, suboptimal afterload reduction, and increase the oxygen consumption, demand and consumption of the myocardium. So late deflation of the balloon during the diastolic phase, if you see the assisted aortic and diastolic pressure may be equal to the unassisted aortic and diastolic pressure. So there is no difference between if the patient augmented or not. Rate of raise of assisted systole is prolonged, and the diastolic augmentation may appear widened. So the physiological effects after load reduction is essentially absent. Increase the myocardial oxygen demand and consumption due to the left ventricular ejection against a greater resistance of contraction phase. So maybe embed left ventricular ejection and increase the afterload. So we are going here to the indications for the balloon use. First is cardiogenic shock after MI, mechanical compilation of MI, either MR or VSD, in association with CABG, patients with severe LV dysfunction, with intractable ischemic arrhythmias. 3, in association with non-surgical revascularization, high-risk coronary interventions, which are severe LV dysfunction, left main, complex coronary artery disease. Contraindications, aortic insufficiency, aortic dissection, and severe aortic and peripheral vascular atherosclerosis. So techniques of insertion, usually inserted into the common femoral artery either by percutaneous technique or surgical cut down. A catheter may be inserted in anticipation of the balloon use. So alternates, there are iliac, axillary arteries, and abdominal aorta are infrequently used in patients with severe aortoiliac or femoral occlusive disease. Placement of the balloon through the grafts seen into the subclavian artery is a strategy that is allowed ambulation, so it has two advantage. It's the patient allowed to ambulate and waiting for the next stage of therapy. So the positioning, the end of balloon should be just distal 1 to 2 centimeters to the takeoff of the subclavian artery, as you see here in the X-ray. The balloon is just 1 to 2 centimeters at the aortic knob. So it's about 2 centimeters away from the takeoff of the left subclavian artery. Expected changes in hemodynamic profile. Decrease in systolic blood pressure by 20%, increase aortic diastolic pressure by 30%, increase the mean pressure, reduction of the heart rate by 20%, therefore reduce the myocardial oxygen demand and consumption, decrease in the pressure by 20%, and elevation in the cardiac output. Timing, we are going to talk about the timing of the balloon during ECG and arterial waves, as you see here. ECG inflation is set for the peak of the T wave at the end of systole, with deflation just before or on the R wave of the ECG. If you look to the arterial waves, inflation should occur at the dichrotic notch, with deflation just before onset of the aortic upstrokes. So removal. Percutaneous balloon pump can be removed without exposing the femoral puncture sites. The exit site is prepped and securing sutures are cut. The balloon catheter disconnected from the pump and completely deflated using a 50 ml syringe. And the proximal artery is compressed and retrograde bleeding is allowed, which flushes any distal clots into the wound. So the distal femoral artery then compressed and antegrade flushing then is allowed. Finally, steady non-occlusive pressure is held over the puncture site and maintained for 30 minutes. If the balloon is inserted via cut down, preferably to remove it in the OR for possible repair of the common femoral. Complications, it's vary between 12 to 29%. Leg ischemia is the most common of them, incidence about 9 to 25%. Balloon rupture and thrombosis within the balloon, septicemia and infection, bleeding, forced aneurysm formation, and lymphocyte. The pre-insertion status of the pedal pulse should be determined and examined before the insertion of the balloon pump. So we would know the ischemia is happened or no, or the pulse is decreased in the lower limbs. Okay, time of insertion affects hospital mortality. It's the timing of insertion of the balloon pump. If it's associated with mortality, if it's preoperatively about 19%. If it's intra-op decision to insert the balloon pump, it's about 32% mortality. And if it's post-op, about 40% mortality. And prophylactic is not routine, as we mentioned in the guidelines. So this is the 2018 guidelines for myocardial revascularization, which is class 3B, selected patients with acute coronary syndrome with cardiogenic shock. Short-term mechanical support may be considered depending on patients' age, comorbidities, neurological status, and the prospective long-term survival and predicted quality of life. And it is not recommended at all if it's routine use in the acute coronary syndrome patients. So the New England Journal of Medicine, it's a study about 600 patients who presented with acute MI and cardiogenic shock, who were be treated with revascularization strategies. 300 patients received and balloon, and 298 patients were treated medically. There was no difference in 30 days mortality and also no difference in adverse events. The next one is direct circulatory support. The ideal device should be capable to provide adequate flow, maximize hemodynamics, unload the left ventricle, fits all patients of all sizes, diminish risk of infection, and avoid inflammatory responses. Indications: bridge to decision, bridge to bridge, or bridge to transplantation. In terms of hemodynamics, cardio index low, below the 2.5, 2.2, blood pressure, systolic blood pressure less than 90, and wedge pressure more than 20, which contain use of committant use of 2 inotropic, so if the patient's in high inotropic support. Devices currently approved by the FDA includes these 5 devices: veno-arterial Ecmo, Impella devices, thoracic Centrifugal, thoracic cochlear VAD or PVAD, and tandem heart system. We're going to talk about them, inshallah. So let's start with Ecmo. It's a direct extension of the principles of the bypass, the cardiopulmonary bypass. The system consists of the following: membrane oxygenator, with an integrated heat exchange system, centrifugal pump, heat exchanger, and circulatory interface between the patients and the system, biocompatible heparin bond bypass circuits. So if you see this, the Ecmo machine with its circuits, it's principal desaturated blood is drained through the venous cannula, CO2 is removed, oxygen is added through the device, the blood is then retained to the system, to the systemic circulation through the vein, if it's a veno-venous Ecmo, or artery in veno-arterial Ecmo. Indications: hypoxemic respiratory failure, hypercapnic respiratory failure with an arterial pH less than 7.2, acidic patients, ventilatory support as bridge to lung transplantation, cardiac circulatory failure, refractory cardiogenic shock, massive pulmonary embolism, cardiac arrest, or failure to wean from cardiac bypass after cardiac surgery as bridge to either cardiac or lung transplantation or placement of a ventricular assist device. Technique: cannulation, it's either central or peripheral. Central intraoperative with extended right atrial and aortic cannulation, peripheral surgical cut down, or percutaneous insertion. So arterial cannulas of 16 to 20 French and venous cannula of 18 to 25 can be used. A long venous cannula is directed to the right atrium under TE guidance, and if you can see the bicaval view. An 8 to 10 French perfusion cannula can minimize limb ischemia, so the patient will not, the patient lower limb will be perfused well during the use of Ecmo. Using Ecmo flow of 4 to 6 liters per minute are possible. Maintenance and monitoring. Once respiratory and hemodynamic goals have been achieved, flow is maintained, oximetry, pressure monitoring, vital parameters, flow rates, neurological status, and vascular status to be monitored. Anticoagulation with the use and fraction heparin with ACT targets from 180 to 210. Complications: bleeding, thromboembolism, cannulation related, heparin-induced thrombocytopenia, neurological complications, and leg ischemia. This is one of the cannulas, cannulation related, which is lower limb ischemia, vessel perforation with hemorrhage, arterial dissection, bleeding, and distal ischemia in veno-arterial Ecmo. So insertion of distal perfusion cannula in femoral artery distal to Ecmo cannula, as you see here. So one of the complications is the Harlequin syndrome, north-south syndrome, as you see here. Yes, it's a saturation of upper parts of the body is lower than that of the lower half. Physiologically, this happens due to the flow competition in aorta recovering heart versus Ecmo pump. So high cardiac output from native recovering heart prevents the retrograde flow of Ecmo to perfuse upper part. If pulmonary function is impaired, so blue head and red legs, deoxygenated and hyperoxygenated lower limb. So we are jumping to the newer devices.
Can you stop?
Yes.
Can you go back to the? Okay, we'll go one by one because these are important slides, and I think it's for cardiac surgeons. It's really important for you guys to understand these concepts. Can you go back one more slide as well, or two more slides? Okay, another slide. One more slide, Ecmo slide. Anyway, so what is the difference between the Ecmo circuit and the cardiopulmonary bypass circuit? The main fundamental difference.
The ambulance, we can move the patient with it.
Oh, this is the only difference?
No, there are other difference.
No, there is one primary difference, or the main difference between an Ecmo circuit and a CPB circuit.
The airing.
It has a reservoir. The
exactly, the
cardiopulmonary
reservoir.
bypass circuit.
Exactly, the reservoir. The reservoir. What is it called? Closed circuit versus open circuit.
Yes.
Okay. What's a closed circuit?
Closed circuit is the Ecmo.
Ecmo is a closed circuit. There is no venous reservoir. So all the blood is either in the cannulas or inside the patient. In cardiopulmonary bypass, we drain the patient. Yeah, 1 liter, 800 cc to 1 liter is in the venous reservoir. We can control how much blood flow there is in the heart and inside the body. And this important concept, differentiation, is really important in managing ECMO and is really important in actually addressing one of the complications of ECMO therapy, which is LV distension. Okay, in cardiopulmonary bypass, you can actually unload the heart completely. In ECMO, you can only unload the right side, but the left side can actually be overloaded and distended. And this is one of the negative impacts of ECMO therapy on the heart, is LV distension. Okay, so an ECMO circuit is a closed circuit with no venous reservoir, inability to control how much volume there is in the heart. You are only able to drain the right side with ECMO. So can you go on to the next slide? So this also has implications with anticoagulation. With a closed circuit, you don't need full heparinization. You only need partial heparinization. You don't need an ACT of 460 and above like cardiopulmonary bypass, which is an advantage to ECMO. You don't need full heparinization. Okay. Next slide, please.
The ACT is supposed to be 180 to 200, yes?
Yes, exactly. So partial, and sometimes you can go without heparin for days. If the patient is bleeding, no heparin.
No heparin.
But reverse the protamine. Let's say you're dealing with a post-cardiotomy situation. You reverse the heparin, you put the patient in ECMO. The patient can stay without heparin for days because the newer circuits, the Mackay CardioHelp, is heparin coated. As you mentioned that in one of your slides, heparin bonded. So you actually don't need heparin for the first few days to stop bleeding. Yes, and because it's a closed circuit, you can get away with it for a few days. But once the duration extends beyond that, you get into problems such as oxygenator failure and high delta P, high pressure gradient across the oxygenator. Okay.
But any experience of thrombosis, doctor, during the ECMO without heparin?
Can you say the question again?
I say, do you have any experience? Have any experience that the ECMO done without heparin and there is no thrombosis done happen?
Of course, all the time. We get patients, let's say post-cardiotomy, a patient who needs an ECMO. We reverse heparin, protamine. You put them on ECMO. You send them to the ICU for the first day or two without heparin. It's important to maintain full flows, okay? Because low flows can lead to thrombosis in these situations. Sometimes you put in ECMO. We had one recently. We put in a VV ECMO on a patient, a trauma patient with liver laceration. We inserted the ECMO, no heparin. Few days with no heparin. Then we started heparin later, and the patient was decannulated. Yeah, so we get into these situations all the time.
Okay, doctor. Okay. No ECT following up, nothing.
You don't. If you don't have heparin, why would you follow up ECT?
I mean, after we starting heparin, in some cases after 3 days, if we just say it.
Yeah, if you want to restart heparin, of course you do ACTs. You follow ACT, but in some situations, anticoagulation is contraindicated, like coagulopathy or trauma patients like that. So yeah, so you can leave them without anticoagulation for a day or two.
Okay, sure.
Okay, next slide.
But Dr. Haytham, if I may, this patient you just mentioned is a patient where the synthesis part of the liver is not functioning. That's why the depletion of the factors that we can ignore the part of the anticoagulation for those.
No, it's not that. It's not that. That's the liver functions were fine in that patient. The patient had trauma, had a liver laceration, and if you put them on heparin, they will bleed.
I see. Okay.
So yes, so north-south syndrome or Harlequin syndrome.
Yes.
Everybody understands this syndrome? Does everyone understand it, or do you have questions about it? Looks like everybody understands it. Okay, so let me go through it. It only happens in peripheral VA ECMO. Only happens in peripheral VA ECMO, where you have a femoral cannula.
Okay.
That is returning oxygenated blood to the body through the femoral artery, and the body goes retrograde to the upper body. The blood flows retrograde to the upper body. And what happens, as you said, in the recovering heart, the blood, the heart will pump blood into the lungs, and the lungs are usually in pulmonary edema. Okay.
Yes.
The blood will return unoxygenated, and the heart will pump unoxygenated blood to the upper body, to the brain and to the coronaries. And this has a very detrimental impact on coronary perfusion and on brain perfusion. Okay. If goes unrecognized, it will be lethal. The patient will not wake up and the heart will not recover. So in every patient with peripheral VA ECMO, there should be a SAT monitor on the right upper extremity. Okay, SAT monitor on the right upper extremity to monitor saturation. A lot of the time, you take a blood gas from the femoral and it's perfect, but the right upper extremity saturation is 80%, for example. And it's true, it's 80%, because the upper body is preferentially produced by deoxygenated blood pumped from the recovered heart. Okay. And this has to be recognized and treated immediately. How do you treat this?
Decannulate first.
Decannulate if the patient is not ready.
Oh, okay.
How do you treat? How do you
higher oxygen supply?
Higher oxygen. Yes, you can increase the FiO2 in the lungs, ventilate the lungs. So yes, that's one way to treat it. Ventilate the lungs.
Jugular cannula.
Jugular cannula. What does that mean? Explain.
Insert the new cannula.
Yes. So exactly. Change the configuration from VA ECMO to VAV.
Okay.
VAV. So you insert another return cannula in the jugular vein. That's one way to treat it. 3. Third way to treat it is stop inotropes. Stop the heart from ejecting, although it's not advised. You want to maintain some ejection of the heart. Option 4 is actually to switch to central ECMO if all fails. Okay. So turn up the FiO2 on the lungs. Number 1. Number 2 would be adding a venous cannula in the upper body. Number 3 would be to switch to central cannulation. If you switch to central cannulation, you will solve the problem. Okay.
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 Okay, doctor. Yes.
Carry on. Continue.
Thank you. So the newer devices, the CardioHelp, it's a compact ECMO system with a low priming volume and integrated oxygenator, small size, good for transport, safely transporting patients with cardiogenic shock. After arrival at the accepting hospital, overall survival was 62%. This is the CardioHelp machine. The tandem heart is a percutaneous ventricular assist device. If they approved for short term, less than 6 hours, cannula are introduced from the femoral vessels by either percutaneous or direct insertion technique. Cannulas delivered across the atrial septum, outflow typically is directed into the common femoral artery. Position is facilitated and confirmed by fluoroscopy, excellent left atrial decompression, as you see here in this image. Doctor, I have one question here. The outflow and inflow cannulas, I mean the outflow is to the left atrium and inflow to the femoral vein, yes?
Hello?
Yes,
Sorry, I
doctor,
was talking with
you hear
the,
me?
sorry, I was talking with the mic was muted. You're
It's okay.
talking about the tandem heart, صح?
No. I'm talking, yes, tandem heart, exactly.
Tandem heart.
Just the outflow and inflow and the mechanism of action.
Okay. Inflow. Femoral vein, transeptal puncture into the left atrium. So
okay.
you remove blood from the left side. You unload the left side.
Okay.
Goes back to the pump. Blood goes to the pump and it pumps it to the peripheral artery, femoral artery. Okay, that's the outflow. So one advantage of the tandem heart over ECMO. Can you explain this to me? Can you give me one advantage of tandem heart over ECMO?
This has I think this has a vent, doctor, to the left system.
It is a vent by itself. It is a vent by itself.
Because
so basically it has
no,
yes, it has much better unloading.
Yes.
And in one of your first slides, you mentioned that the goals of mechanical circulatory support is restore circulation, maintain organ perfusion, and unload the LV. Exactly. Unloading the LV is a very important concept in cardiogenic shock if we're talking about recovery. Myocardial recovery, you cannot achieve myocardial recovery without ventricular unloading. What do I mean by ventricular unloading? In situations of acute cardiogenic shock, your LV EDP, your left ventricular end diastolic pressure, becomes exceedingly high. You increase the stress on the wall of the heart, you increase the infarct size, you interfere with coronary perfusion. This is a bad situation that has to be immediately dealt with if you want to achieve recovery. And bridge to recovery. If we're talking about bridge to transplant or bridge to LVAD, it's fine. You don't need to worry much about it.
Yes, doctor, I have one experience of one patient.
Unloading recovery is very important. And yes, ECMO is especially poor at LV unloading.
Yes, doctor, the patient underwent ECMO, and after 2 days, the patient right ventricle went very well, but the LV was diffused, inflated, and it is poorly ejection. And they decided to take the patients back to the OR, and they put an event with an ECMO, which is gets improved significantly in this patient.
Exactly. So if you let's say you end up in a situation where you don't have a tandem heart or an LV unloading device, you only have ECMO, so you have to couple it with a vent.
Exactly.
So what you have to put an ECMO with an LV vent. So what kind of LV vents do we know about? How do you put an LV vent? An ECMO.
Yes, through apical, doctor.
That's one way. Yes, apex, LV apex.
Yeah, through the apex or through the pulmonary veins.
Yeah, salam. Right superior pulmonary vein, like we do surgical.
Yes.
Okay. Another way. Another way of venting the LV during ECMO.
I'm not sure.
It's atrial septostomy.
Okay.
You take the patient to the cath lab. You do an atrial, just like the tandem heart picture you're showing.
Yeah, exactly.
They go to the cath lab. They do an atrial septostomy. The LV, the LA, unloads to the RA. LA unloads to the RA, and the RA is drained by the ECMO circuit. So atrial septostomy is a way of venting. Another way of venting is impella. You put in an impella across. So they call it, this configuration is called Ecpella. ECMO with impella is called Ecpella.
We are going to talk about it, doctor, inshallah.
طيب تمام. If you want to achieve recovery, ECMO is not your friend. You have to add in another strategy.
Exactly.
Okay. You have to either switch completely from ECMO to a Centrimag or impella, or add in a vent or impella. Okay.
Okay.
Continue, please.
Yes.
I hope this is clear. And if you have any questions, please stop at any point, because I don't advise you to delay your questions to the end of the presentation, because if you delay your questions to the end, you will forget most of them. Interrupt and ask immediately. Okay. If anybody has any questions, go on.
Okay. So most of the experience has been in the cath lab to facilitate the high-risk PCI Flows, it's up to 4 liters are typical with surgical cannulas up to 8 liters. When placing a long-term VAD in a patient on tandem support, it is necessary to repair the atrial septum. SCT targets about 200. RVAD configuration is also possible, percutaneous and surgical. As you see here. So, Centrimac pump is a centrifugal pump. It requires only a very small priming volume. It can be configured for both right and left side. Central cannulation through median sternotomy, up to 10 liters of support can be achieved. It has FDA approval for 6 hours of use as an LVAD and for 30 days as temporary RVAD.
I have to stop you here.
Yes,
if you go back
I have
to
a
the
question, why RVAD?
Go back to the, sorry, what's your question?
Why it's only for 6 hours for LVAD and LVAD support, and for 30 days as for RVAD. Why this? It's more for RVAD and less than the LVAD.
Because the slide is wrong. It is not approved for only 6 hours for as an LVAD. Okay, FDA approval is for 30 days, and off-label use can be up. I've seen it up to 11 months to 1 year as an LVAD. And what you mentioned there in the slide is only for 6 hours as an LVAD. I don't know the source, but it's completely wrong.
Okay.
Completely wrong, okay? FDA approval is for 30 days for both as an LVAD or an RVAD, but this pump is very durable and can be used. I have seen it up to a year. So Centrimag pump, do you guys know what a Centrimag pump is? And
it is continuous, doctor. It's not a roller.
Yes, continuous centrifugal flow pump.
Yes.
Centrimag is the same design as the Heartmate 3. It's just a bigger pump. It's the same manufacturer. Okay? Same manufacturer. Yeah. Same designer. The first design was a Centrimag. And when it was successful, they basically made it smaller and made it into a Heartmate 3. Okay, so it's a fully magnetically levitated centrifugal pump. Same principle as the Heartmate 3. Very high flows, low friction, continuous flow pump, lower stroke rates, excellent unloading of the LV, very versatile, can be used as an LVAD, RVAD, or BiVAD.
Okay.
Okay, you can go to the next slide.
Yes, please.
This is the pump. This is what the pump looks like. Next. So basically, if you go to the pump picture, the pump is only the plastic part at the top. Okay. That's the pump. It's very small. Inflow is the top part. البلاستيك اللي جاي من فوق. Outflow, you can see inflow and outflow are at 90 degrees, not in the same axis. And this is
can be consumed in the chest wall.
What's your question? Sorry.
I mean, this one is pericardial or.
This one is extracorporeal. It's outside the body. It sits outside the body. Okay. هذه temporary LVAD. It's a big pump. It's a very large. You can see it's small here, but it's actually a big pump. It's extracorporeal. It sits outside the body completely. It's temporary. It's not permanent. Go to the next slide. This is the BiVAD configuration.
Yes.
Yep. This is the BiVAD configuration for the pump. If you see to the left two cannulas. Inflow coming from the right superior pulmonary vein to the far left corner. That's the inflow of the pump. Sits in the left atrium. Okay. Goes to the pump and back to the ascending aorta.
Yeah.
That's the LVAD. The RVAD. The inflow from the right atrium and the outflow is in the pulmonary artery. Okay. Another way of doing it is to put the inflow in the left ventricular apex. LV apex inflow drains back to the ascending aorta. And LV apex is much better drainage than left atrium through the right superior pulmonary vein. You get better unloading, you get lower LV thrombus formation rate, you get lower stroke with LV apex cannulation. It's just more challenging to perform, not more challenging, but more bleeding from LV cannulation, LV apical cannulation.
Yes.
Okay.
Yes, doctor.
Any questions? You can continue with any questions.
Okay. This is the
yes.
slide, doctor.
So yeah, Levitronics and Hemodynamic. Levitronics was the first company that designed this pump. Then it was sold to St. Jude, and St. Jude was acquired by Abbott Medical. So Levitronics, Centrifugal is actually Levitronics is the old name for it. It was the company that originally designed the pump. It's taken over by St. Jude Medical.
Okay, we are going to talk about the Impella. It's a microaxial pump, both peripheral and central cannulation available. The pump is directed across the aortic valve into the left ventricle. The portion of the cannula of the device, which sits across the aortic valve with an integrated motor, the small diameter of the cannula allow easy coaptation of the aortic leaflets, resulting in minimal aortic insufficiency. So this is the device inserted through the descending aorta to the arch and through the aortic valve to the left ventricle. The Impella is a ventricular support system, pump blood to a body and bypass the left ventricle. This allows the left ventricle to rest and hopefully recover. For patients with cardiogenic shock, this mechanical cardiovascular support system can be sustained in a patient's heart for up to 7 days. This is the device, as you see. It's called the smallest heart system. It's called like this. Deployed under fluoroscopic or echocardiographic guidance as blood is aspirated through the distal tip inlet area from the left ventricle and pumped into the ascending aorta at the proximal tip area of the catheter motor. So Impella sizes and types, it has 2.5 generates up to 2.5 liters per minute of flow and requires a 12 French size catheter. The generates up to the Impella generates up to 4 liters per minute of flow and requires a 14 French catheter. So as the size increased, the flow increased. So Impella.
So in the middle, what do you mean Impella generates up to 4 liters?
It's type 4, doctor, I think, because
it's Impella CP. You forgot so Impella has 4 types actually. Impella 2.5, the first one, nobody uses it anymore. Up to 2.5 liter of flow. It's totally percutaneous, 12 French catheter. Impella CP, totally percutaneous, gives you up to 3.5 liters of flow and 14 French catheter, totally percutaneous. Impella 5, you can continue. Impella 5, yes, gives you up to 5 liters of flow.
Impella 5,
it's a 20
rates up to 5 liters per minute of flow, but required a 21 French catheter, surgical cut down to this femoral artery, or more commonly insertion through a vascular graft sewn to the axillary artery is required. Now I've seen this one done with the Angioceal or the Brugland.
Impella 5 with Angioceal?
I mean Angioceal before insertion of the Impella 5, so after removal or they can secure the vessel.
Okay, excellent. So no graft?
No graft, no.
21, ممكن. Exactly, it's possible.
I have seen this, doctor.
Where did you see this?
In the Prince Sultan Cardiac Center.
MashaAllah. With Angioceal or Proglide?
Proglide.
Proglide, huh?
Yes.
Yes, it can be. It can be done. It can be done. No surgical grafts, but I mean, in theory it can be done. I've never seen it, but it's good. So there is another Impella called Impella 5.5. Are you going to mention this or? Impella 5.5. Will you mention this or no? الو سامعين يا اخوان ولا؟
سامعينك يا دكتور، سامعين.
معك دكتور.
طيب
عبد الاله
لانه
Yes.
المقدم موقف. اسالك are you going to talk about Impella 5.5 ولا should I talk about it?
No, Doctor, I will not talk about it.
Okay, so the newest generation is 5.5, Impella 5.5. Still gives you up to 5 liters of flow. It has a smaller delivery system, more steerable, more user friendly, less risk of thrombolysis.
Okay.
Okay, so one of the problems with Impella is hemolysis and hemolytic anemia. So with Impella 5.5, this is much less of a problem. Okay, but one of the downsides of Impella is the high cost of therapy. Impella approximately, the 5 is approximately 120,000. The 5.5 is 150,000 per use. That excludes the cost of daily patient care. This is only the cost of the pump. 150,000 ريال.
Okay.
Yes, it's too much for a device that's for temporary use only.
Okay. So Heartmate, it is a micro axial pump similar to Impella. It's designed to be placed through the femoral artery and directed across the aortic valve into the left ventricle. The pump is introduced through 13 French introducer, which allows for percutaneous insertion. Once the pump is in the left ventricle, the segment of the catheter that houses the pump is unsheathed and expands to 24 French. It is then withdrawn, so straddles the Okay, this is the device, Doctor. One second. Yes, this is right. Then they are so biventricular. Weaning trials is usually attempt
عبد الاله.
هلا دكتور.
راح الشيرنج حقك.
مشكلة دكتور عندي كونكشن في النت. I am sorry. I apologize for all of you. One second. Okay, I will talk about the device selection. So it's a few slides, Doctor. I can just say it before without presenting. Do you hear me?
Okay, yeah. We are
Yeah,
hearing
it's just slides with the device discussion. So as you see here, it's no data to recommend one device for another. Selection usually is being on availability. This slide is the one. Patients undergoing CPR are best served by urgent femoral cannulation. This avoids time to delay for transportation of the patient, and sternotomy patients with severe hypoxia and lung injury benefits from the oxygenation and lung rest provides with Ecmo. So post-cardiotomy support, typically patients are supported for 48 to 72 hours while transplant evaluation is completed. Okay. So patient management, ideally pump flow will achieve a mixed venous saturation of greater than 70%, low. Yes, next one. Yes, excessive pump speed, hemolysis. Yes, yes, this slide is the one. Fluid administration is the best way to increase flow. However, right-sided heart failure also may manifest as low flow states in the presence of low pulmonary artery pressure. Okay, we have key points. We reached the key points. Recognize cardiogenic shock in the preoperative and postoperative patients have available at your institution, at least one of the available temporary support system. Initiate pharmacological and first-time mechanical support, the balloon pump that we talk about in the shock patients, attempts to treat a causative issue. Recognize when these conservative methods fail and acts quickly to implement direct cardiac support to restore adequate in-organ perfusion and decompress the heart. Initiate discussion with a center at which advanced heart failure therapies, so transplant or long-term VAD, are possible. Stabilize the patients and initiate transport to a tertiary center or a definitive therapy weaning. That's it. Thank you so much.
Thank you, Abdulillah. Again, thank you, Dr. Haytham, for his brilliant additions to our academic activity. So if any question or any comment to Dr. Abdulillah, the floor is open.
You're welcome. It's my pleasure. This topic is a rapidly evolving area in cardiac surgery, and the management of acute cardiogenic shock has changed a lot in the last few years, just because of the evolution of new therapies and new devices and the recognition of new concepts. So yeah, it's an exciting field, and there are a lot of changes that happened already, a lot of changes that are happening in the field of short-term mechanical circulatory support. Any questions?
Dr. Haytham, thank you so much. We are glad to have you here today.
You're welcome. My pleasure.
Thank you, Dr. Haytham.
شكرا لكم. I'll leave you guys to the journal club. Okay?
Thank you, Dr. Haytham.
Thank you so much. شكرا لكم. توفيق يا رب.
شكرا. Okay, the journal club will start on 3:40. So Muslim, you can start at 3:40.
Sure, Doctor. Assalamu alaikum. I'm Dr. Muslim Al-Musawi from Saudi Al Cardiac Center, Dammam, presenting to you the momentum trial comparing between the Heartmate 2 and Heartmate 3. So background, left ventricular assisted system improves survival and quality of life in patients with advanced heart failure refractory to medical therapy. As you can see in the chart, here the continuous flow LVAD has superiority than the pulsatile, and LVAD in general is superior to medical therapy. Despite improving survival and quality of life, patients with continuous flow LVAD are burdened with hemocompatibility-related complications due to the function of the device, consequences of the adverse interactions between the pump and circulatory blood elements. So what happened? The pump thrombosis, stroke, and the GI bleeding increased. So here is the comparison between the Heartmate 2 and Heartmate 3. The external components of both devices are the same. The internal component is different. As we spoke earlier, as mentioned earlier, the axial flow causing more distraction to the red blood cells, and having rotators inside the blood causing heat, which may generate the, which may enhance the coagulation cascade. While in the new technology, the driving force is the magnetic field. There is no internal compartments. Here's the table showing the differences between the Heartmate 2 and Heartmate 3. Main difference is the flow. The flow axial in Heartmate 2 and centrifugal using the magnetic field in the Heartmate 3. There's no inflow graft in Heartmate 3, and also the technology in Heartmate 3, for example, the modular drive line, electronics incorporated in pump and software in the pump, and also the battery life is 20% longer in Heartmate 3. Purpose of study aims to evaluate the safety and effectiveness of Heartmate 3 by demonstrating non-inferiority to Heartmate 2 when used for the treatment of advanced refractory left ventricular heart failure, irrespective of primary implant strategic intent. Was it the bridge to therapy or destination therapy? Bridge to transplantation or destination therapy? Here's the study conducted in the United States as a multi-center, 69 hospitals or institutions participated. The trials run into three phases. The first phase is the short-term cohorts with 294 patients in 6 months. And the second is the long-term cohort with 366 and 2 years follow-up, and the full cohort with 1,028 patients for 2 years follow-up. Here is the outcome of the first short-term cohort, which was the Heartmate 3 superiority driven by the reduction in pump thrombosis, which was obvious from the start of the trial. The long-term cohort shows lower incidence of non-disabling stroke with Heartmate 3. So the population of the study, inclusion criteria, age more than 18, body surface area more than 1.2 meter, NIHA class 3 and 4, left ventricular ejection fraction less or equal to 25%, advanced heart failure defined as inotropic dependent, or a cardiac index less than 2.2 without inotrope, and either of an optimal medical therapy for at least 25 days out of 60 days, and advanced heart failure for at least 14 days, and dependent on intra-aortic balloon for at least 7 days. This is the inclusion criteria, and the exclusion criteria. Etiology of heart failure is uncorrected thyroid disease, obstructive cardiomyopathy, precardial disease, amyloidosis, restrictive cardiomyopathy. Technical factors: existing durable mechanical supporting device for pregnant patients, mechanical aortic valve that will not be either converted to bioprosthesis or overswing at the time of LVAD placement, history of organ transplantation, platelet count less than 100,000, psychiatric disease or disorder. History of confirmed and treated abdominal aortic aneurysm more than 5 centimeters in diameter within 6 months, active uncontrolled infection, intolerance to anticoagulant or antiplatelet therapies, or any other peri or post-operative therapy that the investigator will require based on the patient's health status, presence of severe end organ dysfunction or failure, moderate to severe aortic insufficiency without plans for correction during the LVAD placement, pre-albumin less than 150 or albumin less than 30, planned by VAD support candidate or known hypo or hypercoagulable states, predicted survival less than 24 months outside the heart of heart failure, for example, cancer patients. Baseline characteristics: we have the age, the gender, race, ischemic cause of heart failure, intravenous inotropic agents, intra-aortic balloon pump, serum creatinine 1.4, the serum sodium and mean arterial pressure, also Intermax score, also the intended goal of pump support. The interventions: patients randomized 1-to-1 randomization performed with the use of permuted blocks, stratification by study center. The data collected at day 1 week, and discharge 1 month, 3 months, and every 6 months until 2 years. Recommended aspirin 81 to 300 full dose, 325 milligram daily, or warfarin with a goal of 2 to 3 INR. NIHA classification and 6-minute walk test performed by trained technician. Primary endpoint assessed as intention to treat, but all secondary endpoints assessed as a protocol. Here is the primary endpoint. So the Heartmate 3 show non-inferiority to Heartmate 2 with absolute difference of 12.1 and very significant p-value, and also shows a superiority with very significant p-value. And the principal secondary endpoint, which was the pump replacement within 24 months after implantation, as you can see, is 12 in Heartmate 3 versus 57 in Heartmate 2 patients with a very significant p-value. The adverse effects: we have the suspected or confirmed pump thrombosis was 7 in Heartmate 3 versus 70 in Heartmate 2 with a very significant p-value again, and any stroke, very significant p-value. The bleeding, also very significant p-value, specifically GI bleeding. The other parameters or adverse effects, for example, the infection was equal in both population of the study. Cardiac arrhythmia also, and hepatic dysfunction, respiratory failure with non-significant p-value. For the rehospitalization and discharge, median duration of rehospitalization in Heartmate 3, 13 days, while in the Heartmate 2 is 18 days. The median duration receiving the LVAD support outside hospital was 653 days in Heartmate 3 versus the 605 days in the Heartmate 2, and the rate of rehospitalization of any cause was 2.26 in which was less in the Heartmate 3 group, while it was 2.47 in the Axial flow, which is Heartmate 2. So the criticisms, this study was an open label design, allows for bias in outcomes assessment, which is in particularly important with a clinically driven outcome. For example, the reoperation. It is possible that treating physicians were more likely to refer for reoperation in patients known to have the second generation LVAD. However, given the magnitude of the decision to embark upon reoperation, the effect of this bias is likely modest if really present. Given only 2-year follow-up period, it's too little, I think. The effect of possible longer-term complications of the third generation device, such as the outflow graft twist or electrical failure, which have been described, cannot assist the certainty. Also adding to that criticism, the funding study supported by Abbott, which is the manufacturer of both LVAD systems, Heartmate 2 and Heartmate 3, and some authors are working in the company and also in other companies such as Medtronic. So to summarize the difference and the outcome of this study, in the largest study performed, the Heartmate 3 has demonstrated a superior performance compared to the Axial. At which aspect? First aspect is the reduction in bump thrombosis, a reduction in stroke of any type, any severity, reduction in bleeding, specifically GI bleeding, and reduction in cardiac arrhythmia, particularly ventricular arrhythmia, reduction in readmissions and days spent in the hospital. This is my reference. Thank you very much. If you have any questions, the door open for discussion, please.
Thank you so much, Dr. Muslim. Any question or comment? The floor is open. So thank you again, Dr. Muslim. I think we can conclude our day. Thank you all and have a nice weekend.